Welcome to this iWorld Live event, and welcome to our new studio. And a special welcome to my good friend Cynthia Matossian. Cynthia, we're talking about an important topic. So we all want good surgical outcomes. Good surgical outcomes require preparation both on the part of the surgeon. We have to know what we're doing. We have to have a good surgical plan. It requires preparation on the part of the patient's anterior surface, because that's where the critical biometry is being obtained. So we talk about managing dry eye and the ocular surface. I understand that. Maybe my patient population is different. I have a lot of patients with meibomian gland dysfunction and have a dysfunctional tear film from that. And, that's difficult to address pre-biometry, except for you, apparently it's not. You've got a plan. So tell me what should I be doing?
Well, number one is to make the diagnosis ahead of time. We have to look at the meibomian glands, image them. And if somebody has a cataract and concurrent meibomian gland dysfunction, we have to pre-treat it in order to get good, reliable numbers that we can plug into our formulas to get our refractive endpoints. So with that in mind, I did a pilot study, 25 patients, where these patients paid for their lipo. They paid for an upgrade of implant if they chose to. I was agnostic to implant brand or type. And what I did is I did their biometry, topography, and keratometry. Then they had their lipoflow, and I waited 6 weeks approximately, brought the patients back, remeasured them, and then did 2 sets of calculations. I based my final outcome on the second set post-lipoflow treatment and used that to actually use that power implant in surgery, but compared the outcome to what it would have been had I used the pre-treatment data. And my outcomes, my data was surprising. 40% of the time, I changed my surgical plan.
That's really, really interesting. So what you're saying, because there are a lot of arguments for optimizing the ocular surface before cataract surgery. One of them is that, well, if the ocular surface is better, the patient's going to see better. But you're saying that your surgical plan actually changed as a result of alterations, improvements to the ocular surface as a result of the meibomian gland treatment that you did. So what are the factors what are the parameters that changed as a result of the treatment that resulted in a different surgical plan?
Exactly. In about 28% of my patients who initially I thought did not need an LRI or a toric IOL ended up needing astigmatism management. That's 28%. In about 8% of patients in whom I thought I needed a toric or an LRI ended up not needing astigmatism management. And in 4% of patients went from toric to LRI because their delta between their flat and steep K lessened so that they were no longer a candidate for a IOL.
That's absolutely fascinating. It really, really is. So what you're saying is that the topography as measured
Yes.
Changed as a result of your meibomian gland management. And of course, what we measure is the anterior surface of the tear film. It's not the cornea. We all talk about
Exactly.
and so you are doing a refractive tear film treatment before TM. By the way, I like that.
I like that too.
A refractive tear film treatment before the biometry. Now, let's deal with the elephant in the room here, which is that a patient's coming in for cataract surgery, and you say, "I want to do this therapy. I know that this therapy is beneficial. I have to charge you for that." How do you manage that?
I discuss it up front with a patient, and I say, in order to get the best possible outcomes, you have 2 problems, cataract and meibomian gland dysfunction. To get the best results, we have to address both, and sometimes both come with an out-of-pocket expense.
Well, of course. Of course.
Depending on the type of IOL.
Yeah. Yeah, really, really interesting stuff, and you're avoiding the wrong astigmatic treatments, and
Exactly.
that that can involve disappointment and money both ways too. Yeah, really interesting.
And the results showed that when I did my post outcomes analysis, is that 92% of the time I was within plus or minus half a diopter, and 88% of the time I was plus or minus a quarter of my refractive target.
Yeah, that's really, really fascinating. You make a very compelling case. Cynthia, I'm going to have to give this some real thought. I mean, it's really, really interesting. And, you know, I want better outcomes. We all do.
And
Uh,
so do the patients.
yeah, and so do the patient. Yeah, no, I want my patients to be happy. I know that's not novel. Cynthia, I want to thank you very much for making what sounds like a very simple topic very complicated, then re-simplifying it for us. That's quite the trick. I want to thank you most of all for the generosity of your time with us today. And I want to thank you,
Thank you.
our live audience, for participating in this event in our new iWorld live studio.
Great. Thank you.